Hi, this is Brian Kim. I want to share with you this case of a patient with a dislocated single-piece acrylic lens with a CTR complex. Now, this patient had cataract surgery with me 6 years ago, and when I did his cataract surgery, I noticed that his bag was a little bit floppy, so I put in a CTR really as prophylaxis to see if it would help stabilize the capsular bag. Well, studies have shown, and this case also shows, that the CTR does not actually prevent dislocation of the lens bag complex. And so you'll be able to see that right here. In this case, this patient is at the slit lamp here, and you can see the CTR eyelet is at about 11 o'clock. You can see it's on the pupillary edge on the top, and you can see that round eyelet there, and you can see the optic has sunset at about 60%. And so you can see that optic has shifted down, and now this patient is on the table, and actually the lens is actually shifted upward now. And so what I'm going to do in my plan of attack is perform a scleral lasso suture technique using CV8 Goretex. And so right now what I'm doing is making my paracentesis incisions for my iris hooks. The iris hooks are very important so I can retract the pupil right over the area of action so that I can lasso the suture around the CTR and lens complex. And you can see here people kind of fuss about how difficult it is to put iris hooks on. And you can see I was able to put the hooks on fairly easy. Again, the more you use instruments, the less cumbersome and tedious they are. And so really I don't prefer putting rings in. I feel like the hooks work quite well for me. Again, in this case, quite efficiently. This is some dispersive viscoelastic to fill the anterior chamber, coat the corneal endothelium. You can see the lens is pushed back some more as well. So that's actually good. It's going to help me visualize to lasso the CTR and scleral fixated. So I'm doing a peritomy first on the right side, and then now on the left side. And you want to make sure you get down to bare sclera. It's really annoying if you're trying to make scleral grooves and suture placement when you're getting some of that flimsy episclera and the tenons. And now I'm down to bare sclera. You're going to perform a little bit of cautery because you need to make sure that the surface is dry. And so I'm using the tip of a cannula to mark the limbus. And then I'm cauterizing on the other side. Again, we want to make sure you get it nice and dry. And then I'm finding 180 degrees apart. And this is another tip. Going to low mag helps get that perspective and orientation. So going low mag, I'm able to find 180 degrees apart, and then I'm placing that mark at the limbus. And then the caliper is set at 3.5 millimeters posterior to the limbus. So 3.5 millimeters posterior to the limbus. And again, I'm marking, indenting with the caliper, drying with the cotton tip, and then marking with the cannula tip. And then I'm going to go about 1.5 millimeters posterior to the limbus. So I'm making two marks, 1.5 millimeters posterior to the limbus, and then also 3.5 millimeters posterior to the limbus. And I'm going to make that scleral groove, which will be essentially 2 millimeters long. Again, 3.5 millimeters back and about 1.5 millimeters back. And then I'm going to use my diamond blade to make a partial thickness scleral groove. And it's going to be a vertical groove in such a way that the lasso is going to be able to go vertically and loop around the CTR. And I enter through the groove on the superior side. And that's because I'm going to penetrate through the inferior aspect of the groove with the needle instead of making a sclerotomy with the blade. So you can see I made my main incision. I'm working temporal here. Putting some more viscoelastic, cohesive viscoelastic, push that lens back. I'm rotating and going to approach superiorly now. And all of this requires a lot of planning. I'm bending the needle. You need to make the needle nice and straight. I'm using two needle drivers to bend that needle straight. So I'm placing that needle through the superior limbus. Using micro graspers to pull it in a little bit more, and I'm positioning that needle right there, right where the CTR is going to be, and you can see that's the haptic, the single piece acrylic lens haptic right there. That's, again, inferior. And then here you can see the CTR. That's the CTR loop right there. And so I'm going to position that needle right there, and I'm going to make sure I stab through the capsular bag underneath the CTR lens complex. So this is a 25 gauge needle. I pierced through the inferior aspect of the groove, again, 3.5 millimeters posterior to the limbus. And now I'm ready to go. I'm underneath it, and I'm going to stab through the capsule right there peripherally underneath the CTR lens. I'm docking the needle on the 25 gauge needle. As I pull it out, I retrieve it and hold it with a micrograsper, making sure I have good control, disengage the Goretex needle off of the 25 gauge needle, and then I pull it out. So again, because I retracted the iris, I have great visualization of where I'm placing that needle. I pre-positioned it through the limbus with that technique. And I'm going to do the same exact maneuver on the other side. So again, I have iris hooks in place. But before I do that, I'm going to push some more cohesive viscoelastic, and I'm just taking a peek. I'm retracting the iris, and I'm turning the eye downward, and I'm ensuring that that Goretex suture is definitely underneath the CTR complex. My scrub tech cuts the suture. I go through the superior sclerotomy because, again, I use the blade to get in it. I go through the superior sclerotomy with the micrograsper, and now I'm able to grab that free end of the suture, which is definitely going to go over the CTR lens complex. Now I'm going to do the same thing on the other side. I'm placing the needle through the contralateral limbus, placing it inside the anterior chamber, and then I have micrograspers to hold the needle, making sure it's going to go underneath the CTR and lens. With the 25 gauge needle, I'm going to pierce through the inferior aspect of the scleral groove, again, which is 3.5 millimeters posterior to the limbus. I have it right in position underneath the CTR and lens. I'm stabbing through the capsular bag with the Goretex needle, passing it, docking it on the 25 gauge needle, and then pulling out that 25 gauge needle, retrieving it with the microforceps, and then disengaging the Goretex needle from the 25 gauge needle. Pull the Goretex suture out, going in with microforceps through the superior sclerotomy. Again, that's 1.5 millimeters posterior to the limbus. Again, I stab with my diamond blade through that incision there, making sure I am on top of the CTR lens complex. My assistant cuts the suture, and now I'm able to pull it through, and now I have both ends lassoed around the CTR lens complex. And with this, Goretex is not forgiving, so if you yank it too hard, it's hard to loosen it up. So just very gently, I'm just going to do a 1-1-1, and I want to make sure I have even tension. You can see the lens is slightly to the right. I'm going to tighten a little bit more on the left side, and as I do this, you can see it centers a little bit better, trying to loosen it a little bit on that right side, and then tightening a little bit more on the left. So this is going to, again, I'm going to be very gentle, making sure it doesn't slip as I tighten it. This is the most important part. When you're cinching down that suture, you want to make sure you're very gentle, because as you cinch it down, you don't want it to slip and over tighten. And if you do it this way, it locks the knot. And then this is the final throw. This is a 1-1-1. You want to make sure it's nice and snug, just some even tension. You see I roll the knot superiorly. So I roll the knot towards the sclerotomy, and you'll see how that's helpful. So again, I tighten and then I roll the knot to the sclerotomy. And that's because now I'll be able to cut the ends, and then I can just push the knot through the sclerotomy. So that's why, another reason why I like to actually make a stab incision with my diamond blade, because it's a lot easier to bury the knot through a sclerotomy than if you didn't actually make a sclerotomy incision. So again, I'm able to bury the knot very easily because I rolled the knot upward as I was tying it. Now I go ahead and release each of the stoppers, and you want to twirl the iris hook. So if you want to preserve the iris hooks, it's better not to just yank it out. If you yank it out, you're going to damage it. So if you rotate it 90 degrees like that, you'll be able to just pop it out. So you can see how I'm doing that here. Pulling the stopper back, rotating it 90 degrees, and then it pops out. So these iris hooks are so helpful to visualize the peripheral lens and bag, and you saw I was able to very easily recognize and locate where the CTR was. So again, I was able to retract the pupil with the iris hooks. This gave me clear visualization of where the CTR lens complex was, so I can very carefully pass those needles underneath the CTR lens complex, being able to pass it through the sclera, and then using the sclerotomy, that 1.5 millimeter incision, I was able to go through with microforceps and then retrieve the top side of the lasso. And so that was the reason why I did that. Again, 3.5 millimeters back and 1.5 millimeters back from the limbus, made a nice groove. Through the posterior aspect of the groove, I placed that 25 gauge needle. By doing it that way, I don't have an open wound through that part of the groove, but then I was able to lasso through using a docking technique with the CV8 Goretex Suture needle. Again, you have to flatten out that needle in order to make it straight, and otherwise it doesn't really make sense for this maneuver. It needs to be a fairly straight needle. When you're passing that needle from the contralateral limbal incision, you're able to slide it through the anterior chamber, and then with microforceps very carefully and very good control, I was able to carefully place that needle tip, the Goretex needle tip, right underneath the CTR lens complex, stabbing in the peripheral bag, and then docking it on that 25 gauge needle, and then it was able to pull it out. You would think, okay, is it going to damage the capsular bag doing it this way? Because it's such a peripheral stab and it's also a very small stab, it doesn't really tend to disrupt the capsular bag very much there. And again, you're able to have that good support because the capsular bag is covered in tethering like a canvas over the CTR and lens. And so you're able to do that on either side. Again, great visualization either way. I was able to use cohesive viscoelastic to push the lens bag complex, so they're able to push that microforceps through the superior 1.5 millimeter sclerotomy through that superior aspect of that groove. By doing it this way, I was able to confidently make sure that was above the CTR lens complex. I was able to grab the other end of that lasso, pulling it out, and then adjusting tension on either side. Again, doing a 1-1-1 suture throw. By doing it that way, I'm able to adjust the tension. And then I was able to, again, roll that knot up towards the superior aspect of the groove by cutting the suture ends, and then I was able to stuff the knot in through that sclerotomy. And so this patient did very well. You see that the conj is now reapproximated. I did not encounter any vitreous throughout the entire case. So again, this is unusual. With these dislocated lenses, I do tend to see these patients who don't really have much vitreous to really be seen at the end of the case like this. So luckily, no vitreous. Patient had a pressure of 10 afterward, and the patient did quite well. The lens was very well centered, and this, again, the suture knot was buried in this case. Never have exposed Goretex suture knot that will cause problems. And you can see, I think a CTR is a good idea. Again, not for prophylaxis, obviously, but if there's late dislocation, you could take advantage of that CTR and perform a scleral suture lasso technique with a CV8 Goretex suture. So I hope this was helpful to you, and I thank you for your attention.